good morning or good afternoon to everybody wherever they are. Today from Jerusalem, we're going to present a case of a gunshot wound that was managed maybe not in the regular way. Dr. Kahana is a general surgery resident of ours. He will present the case, so we can start.
Hi, hello everyone. My name is Noam Kahana. I'm a resident in the Department of General Surgery here in Shaare Zedek Medical Center. In the next half an hour, I guess, I will present our experience from this interesting case of a thoracoabdominal gunshot injury. So let's start. So the pre-hospital message was about a 49-year-old male without any major illnesses in his past medical history and except a single right kidney. The mechanism was of a gunshot wound by a pistol in his right anterior thorax and the left back. The injuries was, as I just say, left back gunshot wound and another in the right chest, just beneath the nipple. The signs by the EMS team was that he's hemodynamically and respiratory stable, with just mild tachycardia of heart rate of 103. The treatment in the field was just IV fluids and oxygen support, and the transportation, the estimated time of arrival was of half an hour after the event. The initial resuscitation in the emergency department area was intact without any obstruction, breathing, no emphysema, but decreased breath sounds on the right side of the thorax. In his arrival, the blood pressure was preserved, but a few minutes later, the blood pressure decreased to 74 systolic blood pressure and heart rate increased to 140. We put him in 2 IV lines and started with a blood transfusion. This Glasgow Coma Scale was 15, and we noticed that he couldn't move his 2 lower limbs, and he had no sensation beneath the pelvis. On exposure, we saw 2 gunshot wounds, one on the back, just adjacent to the spinal column, and another one in the anterior chest beneath the right nipple. On EFAST, it was positive in the Morrison pouch, and the cardiac FAST was negative. Here you can see the illustration of the 2 gunshot wounds. In this X-ray, you can see we marked the 2 wounds, and we see no obvious bullet and no anything else except signs of hemothorax in the right thorax. The initial venous blood gases was a pH of 7.4, and the lactate was elevated 4.2 without any. The base excess was 2.2. The initial resuscitation included blood transfusion of 2 blood units. We inserted the right chest tube with drainage of immediately almost 1 liter of fresh blood, and we also see a mild epigastric tenderness. The blood pressure after the blood transfusion increased to 94 systolic blood pressure, and the heart rate decreased to 105. The respiratory situation was stable with a saturation of 99%, and the Glasgow Coma Scale was 15. So at this point, what would you do? Would you take him to the theater, to laparotomy, to right thoracotomy, any other idea, imaging?
Let's go to UK for Dr. Viaquirin.
Thank you. Well, as always, we have to start again with, I'd reassess everything, and in the long-term short, if the patient is hemodynamically, it depends on the facilities we have, but we have a facility where we can put him through a CT scanner next door. So I'd probably have a CT scanner done at that moment if the patient's hemodynamically stable. Otherwise, this patient would probably end up in a theater with a right thoracotomy. I'll leave it there so others can participate also. Thank you.
All right, thank you, sir. Boston, Dr. Oyman, your comment, sir.
Okay, you have 2 gunshot wounds and no bullets. I would probably try to do quickly a KUB to make sure that they might not be in the abdomen, but this appears to be just a through and through gunshot wound. So you have a patient who is hemodynamically unstable. We have a scanner and the AD, but I don't know if I would take this patient to the scanner. It all depends. Sometimes it's the way it looks, whatever, but I would probably say no. I would go straight to the operating room. He has blood in the chest, and he probably has some blood in the abdomen. However, the blood in the chest, I think is probably coming from the abdomen, probably has a liver injury. So I think I will start with a laparotomy rather than a thoracotomy and go from there. Thank you.
Thank you, Dr. Oyman. Sao Paulo, Dr. Calais, your comments, please.
In this situation, I put the patient to OR, start with a laparotomy, and then if there is problem to go a right thoracotomy. At the moment, I go to laparotomy as soon as possible.
Thank you, Dr. Calais. Thank God. Dr. Super, your comments, sir.
I agree with taking the patient immediately to the OR, and I should begin with laparotomy first because he had blood in the abdomen from the ultrasound. But I will keep an eye on the right chest tube output, and with supine position, if needed, he can get anterolateral, no, just an anterior thoracotomy, anterolateral thoracotomy on the right. And I think that would be my approach.
Thank you very much, sir. Iraq, Dr. Untrack, your comments, please.
Yes, I agree. It's kind of odd that I assume you're viewing this as 2 entry wounds, no exit wounds, and no sign of metal anywhere in the chest or abdomen. So it's kind of odd. I suppose it could be a entry wound on the right chest, exit wound in the left side across the midline. And I don't know what your thoughts are about that, but I'm assuming they're just 2 entry wounds. So, and I agree with going to the operating room right away. He's got blood in the abdomen, blood in the chest. Part of the decision, I would see how much the tube, there's an immediate gush of a liter. So that's an indication for thoracotomy, but it's still pouring out blood, or is it a liter and he's stopping and he's stable? If that were the case, I might be inclined to put him supine, do the laparotomy, but with the chest prepped in. And then if he destabilized and there was a gush of blood through the right chest, you could either do an anterolateral thoracotomy or a median sternotomy to get control of the hilum. And then the last option would be I suppose a right thoraco-abdominal incision to approach both. And certainly I would consider that if he continued to pour a lot of blood out of the chest tube en route to the operating room. So either supine laparotomy first, or with the potential to extend through the sternum or the anterolateral on the right side, or if he were bleeding a lot through the chest as well, perhaps a thoraco-abdominal incision.
Thank you, Dr. Untrack. So Israel, Dr. Bahram, are you going to participate, or are you just that familiar with the case, or what? You're muted, please.
I'm sorry, we have a bit of problem of hearing, so this is why I'm moving the phone too much, because I couldn't connect with my my computer. I think we're familiar with the case. Someone who is stable, I think I will go and take him to another scan before going to the OR. What do you think?
Not your case.
Dr. Goldstein is agreeing with me. He's here on the side.
All right, thanks. Let's see, I think that's, go ahead. Go ahead, do you have further comment? No? All right, let's go to Dr. Marttos. Would you have a comment, sir?
No, keep it going, please.
Okay. All right, does someone else have a comment before we continue? Okay, back to you, Dr. Schwartz.
So because the patient was a partial responder with elevation in his blood pressure and decrease in his heart rate, we choose to take him to CAT scan to CT angiography. And as you can see, although he has chest tube, there's still retained hemopneumothorax with right lower with lung contusion in the right lower lobe. Here you can see an intersection of the spinal cord with bone fragments in the spinal canal on the level of T12. In this image, you can see a retroperitoneal hematoma with active intrahepatic extravasation. And here you can see the arrow pointing on the narrowing in the intrahepatic vena cava, but without any clear extravasation from this point of the vena cava. We try to make some illustration of the bullet trajectory. So here you can see the bullet the enters in a wound in the back, going through the spinal column between the aorta and the inferior vena cava, but without extravasation of blood. It goes through the upper liver with extravasation in this point, as you can see. The narrowing of the inferior vena cava without any extravasation and getting out through the right anterior thorax. Again. So after the CAT scan, his blood pressure was still around 90 and the heart rate elevated to 150. The saturation was still 99 and the chest tube continuing to drainage more 400 milliliter of fresh blood. We gave him another 2 blood units. So what would you do at this point? Again, would you take him to the theater for laparotomy, for right thoracotomy, any other ideas?
Mm-hmm. Dr. Calais in Sao Paulo, your observations, please.
In this situation, they have the injury or suspecting in inferior vena cava, hepatic vena cava. In this situation, I go to a laparotomy and a sternotomy to get access to the vena cava and the hepatic veins in this situation, in this position. I have to remember these patients because I go through, you can see the esophagus because it is near the aorta and the vena cava in the abdomen, so it can be some injuries in the esophagus in this position. But the access for this surgery, I start with a laparotomy and then stand to a sternotomy, not a right thoracotomy.
Thank you, Dr. Calais.
Dr. Colette, I will say that we saw the vena cava on the CT scan, and there was no extravasation from the vena cava. There was just narrowing, and it was thought to be a hematoma that pressed the vena cava, but there was no extravasation from the vena cava. We had a very good arterial phase and a venous phase, and we saw no extravasation.
Yes, in this situation, you don't have extravasations, but when you go to make a surgery, sometimes they become extravasation. So in this position, I start with a laparotomy. And then if you can stand for approach in these situations, it's very easy to go to a sternotomy. When you go to a right association with a right thoracotomy, you have sometimes you have curve the instruments to go to access this position. This is not very good. So we have the vessels very near on the midline. So I believe it's very easy. If I have problem to do, sometimes I have problem with patients that injuries in this position, and they have association of can find in the surgery injury of the vena cava. I can go to put a shunt. I have put three or four shunts for control hemorrhage in the vena cava in this position. And it's very easy to do this by a sternotomy and not by a right thoracotomy.
Thank you, Dr. Calais. Dr. Untrak, your comments, sir?
Yes. So I gather that based on your comments with Dr. Calais, that you wouldn't do the laparotomy and sternotomy. That would give good access to the vena cava. But in this case, really, it seems that you need access to the posterior liver. And as what I was saying before, that a right thoraco-abdominal incision would give very excellent exposure to the posterior liver. The midline laparotomy, sternotomy, you can put an intracaval shunt if you needed it, but in this case, the patient's blood pressure is reasonable, and you see no extravasation from the vena cava. So really, you need access to the posterior liver. Here I would, if you say other, I'm guessing that maybe that's what you did, and I think that would be a reasonable choice, certainly based on the CAT scan. Also, I'll comment that well, two comments. First of all, so I was guessing maybe it was a single, one was the entry, one was the exit, but I got them reversed, and it seems reasonable the way, looking at the way the spine is injured. The last point I'll make is, solitary kidney, but here you can see a gigantic right kidney, so it's sort of the equivalent of a horseshoe kidney, and I imagine he probably has a double collecting system on that side, but that's really irrelevant to his clinical situation at this point. So.
Thank you, Dr. Untrak. Let's go to UK for Dr. Villaquarian. Your comments, please.
I think I'd start with the laparotomy again. I agree with that I would start with the laparotomy. And if I had to go up, I'd do a sternotomy also. I had thought a right thoracotomy would be indicated, but I would go back and say, yes, I would probably go for the laparotomy and then think about midline sternotomy for this patient.
Thank you, sir. Back in Israel, Dr. Barheim, would you like to comment?
No, I'm pretty much with everybody else about the laparotomy first, and only if I see an indication, I'll go up to the chest. That's it.
Okay. Thank you very much. Bangkok, Dr. Super, your comments, please.
In this case, I still want to perform laparotomy for this patient. And if possible, I would try to use hybrid operating room for this one, because there's extravasation from the liver and maybe possible hepatic artery injury. So if the bleeding cannot be controlled with packing, I think interventional radiology would be the way to go for this patient. So hybrid operating room for him would be the best option. And for the right chest, bleeding maybe it's from a hole in the diaphragm, and the bleeding from the abdomen into the right chest through the hole. So after stop bleeding in the abdomen, suturing the diaphragmatic hole, I would try to observe the chest tube output on the right side. If the output decrease, I don't think we need to open the right chest. But if he continues to bleed from the right chest, I would still perform anterolateral thoracotomy on the supine position. Thank you very much.
Thank you, Dr. Super. Boston, Dr. Hoyman, your comments, please.
Yes, I was thinking before that you showed the video that the injury has to be, if it was just a through and through, needed to be posterior to anterior, as otherwise, if we have been the other way, the bullet most likely than not will have a stop at the level of the spine. They lose enough speed there that when it hit the bone, it will probably stop there. So the trajectory seems to be like this. I am glad I said that I wouldn't do a CT scan probably, and that's because our CT scan, despite being a very recent one, is kind of slow to get this type of studies. But glad that you got it, because it looks to me this went in between the aorta and the IVC. So the guy was very lucky, well, lucky, he's paralyzed, but he was lucky because that tends to be a supraceliac combined aortic and IVC injury tends to be pretty lethal. Almost always, almost time, because it's very difficult to get vascular control. So the bleeding was coming from the liver, which is what I suspected. The majority of these cases do not bleed in the chest. That's the reason I will go to the abdomen. It's bleeding through the liver, from the liver into the chest from a hole in the diaphragm. This is present a very interesting approach because normally we need to mobilize the liver in order to get control of this. Normally what we need to do is mobilize the liver on the right and rotate the liver medially. But this, because you have the CT scan, I think that the injury is in the left hepatic vein, and I will mobilize the left lobe of the liver, which makes my life much easier, because even if I cannot get proximal and distal control of the IVC, mobilizing the left lobe of the liver and resect this is usually easy to get control of the left hepatic vein. I wouldn't be worried about the esophagus because at this level, the esophagus tend to be to the left of the aorta, and this went in between the aorta and the IVC. So I can do an endoscopy if I am concerned at the end, but I think I will do that. I will go for a laparotomy. In the laparotomy, I will mobilize the left lobe of the liver, most likely do a left lateral segmentectomy, and ligate the whatever is bleeding in the liver, and if I cannot control, pack it and go to IR. Thank you.
Thank you, Dr. Lehman. Do we have any other comments before we return to our presenters? Okay.
May I speak of something again?
Yes, sir, please.
Yes, in these situations, you have a hole in the liver and a hole, two holes in the liver. You can have a tunnel through the bullet across the liver. Sometimes to stop bleeding in these situations, when go to the OR, you can use a balloon or a sunk-state Blackmore's tube to put through the injuries and to control the hemorrhage in the liver in this situation. I have to remember that sometimes it's important to think about this because we have to use these equipment or prepare these equipment to control the hemorrhage of the liver.
Thank you, Dr. Calais. Dr. Frisbee, it looks like you have audio now, sir. We can hear you. Would you like to weigh in?
No, I think I'll just keep listening. Thank you.
All right, sir. But as I said, be advised.
And if I can make a comment regarding what Dr. Calais mentioned. A few years ago at this conference, I mentioned another technique, and people laugh at me, and I think they probably will laugh again. Stacking Blackmores are difficult to get by, but a way to improvise one, like particularly for the injury in the liver like this, and please don't laugh at me or not too loud, is to use a condom on top of an NG tube. And you probably have to ask one of the residents for a condom, put it on top of an NG tube, tie it at the end. The NG tube is rigid, so it will go more or less straight in the injury in the liver, and after that you inflate the condom with saline, and that will temporize allow it to go to IR. But that's another option to improvise and overcome. Thank you.
Thank you, Dr. Lehman. Any comments before we return to our presenter? Okay, back to you, sir. Right, your mic is muted.
Okay, so we're probably gonna surprise everybody because we did something else. I want to mention that the patient was given blood and was responsive to blood. So his systolic blood pressure was about 90, which is enough for us. And this is what led us to what we chose to do.
So we decided to take the patient to angiography. And as you can see in this image, we found the right 12th intercostal artery extravasation. And our interventional radiologist made the embolization, and you can see before and after the embolization that the bleeding stopped very well. And another point of bleeding, before the celiac axis, the celiac trunk was fine without any clues to bleeding, and also from the intrahepatic arteries, no bleeding, no extravasation. And another point of bleeding was the right inferior phrenic cutoff, as you can see in this image. And our interventional radiologist also embolized this point of bleeding. So one day after the embolization, we took our patient to another CAT scan. And as you can see, we found no evidence of bleeding or extravasation from any site that I mentioned before. Here you can see the inferior vena cava that looks very well without extravasation. And we want to rule out any duodenal injuries, so we made it with oral contrast, and we found no evidence of duodenal injury. So the post-interventional course was fine without any major event. He received a total of 4 blood units and 4 fresh frozen plasma. He stayed paraplegic at the level of T12 and got evaluation of the spine team. They decided to do nothing. And he tolerated very well oral diet. And we took out the chest tube at post-interventional day 4. And we discharged him to rehabilitation 1 week after the admission. Here you can see a chest X-ray 2 weeks after the discharge at our clinic without any major finding. Thank you very much.
Okay, so I can add that we allow ourselves to go to Dr. Supa idea and to use the hybrid approach. And probably we save this patient maybe laparotomy or thoracotomy, and just with IR intervention, we managed to control the bleeding. The patient allowed us to do it because we gave him blood. He responded well. He had a systolic of 90 or 95. It was enough for us. And this what allowed us, and we felt comfortable with the interventional radiology. So I will be happy to hear your comments. Thank you.
Thank God, Dr. Super. Your final comment, sir.
Thank you very much, Dr. Schwartz, for presenting this interesting case to us. And in my opinion, I wouldn't be brave enough to not perform laparotomy in this patient because the mechanism was a gunshot wound through the abdomen. And besides controlling the bleeding, I would try to look for other occult injuries like pancreatic injury or bowel injury. But with good imaging and good clinical judgment you had, I think the patient got the best treatment for him, and I congratulate you for that. Thank you very much.
I will add that right upper quadrant or right thoracoabdominal gunshot wound of a low velocity, it's a handgun, it's not a rifle, yes, is acceptable by managing in non-operative way, okay, if the patient is responsive to blood. This is not a new thing, that a right thoracoabdominal gunshot wound, low velocity, can be managed by a non-operative way. The CT scan allowed us to see that the gunshot wound trajectory went from the left back actually to the right abdomen, and the bullet didn't pass in the left abdomen. All the trajectory was to the right of the aorta and not to the left of the aorta, which make it right upper quadrant or right thoracoabdominal gunshot wound, with the trajectory that go up through the diaphragm to the chest. As I was educated, this kind of low velocity gunshot wound can be managed non-operatively.
Thank you very much, Dr. Schwartz. Let's go to Boston. Dr. Hoyman, your final comments, please.
This is the beauty of this conference. We learn to do too many things in too many different ways, and it makes us humble that there is more than one right way of doing things. I think that this was a very brave approach, which was the right one, and I congratulate the presenters for doing this, and also thank them for presenting this case, because open our minds to similar approaches in the future. Thank you.
Thank you, Dr. Lehman. Sao Paulo, Dr. Tele, your final comments, please.
Congratulations for sharing the case for us. It's very important to show this management. Sometimes maybe all of the hospitals have all the means to use these techniques to control or to treat no operative management of gunshot wounds. Sometimes in our hospital here, in these situations, I can't go to no operative management for treatment on the gunshot wounds. So it's very interesting to know and how to do this. But in some hospitals, it's not possible. Sometimes the patient needs to go to AOR and make the operation to control the hemorrhage and treat the patient. You have to think about that patients with injuries in the middle of the liver, they become some biliary limb. That's the problem can be seen, you can continue to think about on the post-operative days, on the post-operative, no operative management in this situation. Thank you for sharing. Very, very nice case to see, very nice techniques to approach in this situation. Thank you for sharing the case.
Thank you for your comments, Dr. Tele. Iraq, Dr. Untrack, your final comments, sir?
Yes, so very rare case, very, very artfully managed, and it's very dramatic, learned a lot. Thank you for presenting it. Well done.
Thank you, Dr. Untrack. Let's go to the UK, Dr. Villaquere.
Thank you. I agree with the previous speaker that I would, Dr. Shuka, I would have taken this patient anyway for the laparotomy. I wouldn't have been enough brave to not have left him without a laparotomy and would have closed the diaphragm if needed. But a very interesting case, and thank you very much for teaching us and giving us your experience.
Thank you for your comments, sir. Back in Israel, Dr. Barham, your final comments, please.
I think the nice thing is with this approach that we really got not a lot of blood product. So I think this is one of the most great outcomes that you have from the angio. So it was a very nice case.
I agree, because his injury, eventually what we found in the angiography was 12 intercostal artery. Did you try to reach this kind of artery bleeding from the aorta? This is very hard to control in laparotomy. This is first thing. The other one is the phrenic. Phrenic may be easier, but I think the patient will suffer from more blood loss if we try to control the bleeding from laparotomy by controlling it in angiography.
Thank you. Dr. Stein, your final comments, please.
Yes, I congratulate Alon. It's a great case, but the patient was very lucky, and you were lucky. One thing I'll have to correct is we don't use the term anymore of low velocity and high velocity. We use it low energy and high energy. And I believe that Dr. Ivatori, the famous Ivatori, have already told us that low energy gunshot wounds to the right upper quadrant, tangential wounds to the abdomen, and transpelvic below the peritoneal reflection can be treated selectively by non-operative management, and that's what you did, and it's very nice. I'm proud of you.
Thank you, Dr. Stein. We're going to go to Dr. Marttos for final comments, but do we have any other comment before we turn it over to Dr. Marttos?
So just one thing about just reinforcing the sense of high velocity and low velocity, and it's high energy and low energy, as correctly was pointed out. Some of the bullets that can be fired from pistols or handguns are high velocity. I have, hold on, just give me 1 second. I have some quick examples here, if you don't mind. First of all, that terms of high velocity and low velocity started when it was with military bullets. This is a 9mm, it's a full metal jacket bullet. It doesn't deform. And after that, they came out with bullets that, like this one, which is a hollow point, And these bullets for the handgun, they deform significantly and they release a lot of energy in the tissue. This is a bullet by comparison from an M16, it's a 5.56. This is the difference in size. However, there are some bullets that can be fired from pistols like this one. This is a 5.7 by 28. Can be used in a submachine gun or in a pistol, which are really high velocity. The speed of this is like 2,100 feet per second compared with 1,200 feet per second of a 9mm bullet, or 900 feet per second on a 45 millimeter, 11.25 millimeter, which is the famous 45. So you can have a lot of energy released now from a handgun, which many years ago was thought not possible. So yes, granted, a rifle bullet has more propellant and can cause more significant injury, but you can have really significant injury now from handguns. And the fact that this bullet was able to travel through and through after going through the spine, it showed that it has a significant energy even from the handgun. Just a little bit of trivia, that's all. Thanks.
Thank you, Dr. Horman. Any observations on Dr. Horman's comment? Okay. My apologies, Dr. Marttos. I'd like to turn the floor over to you now.
Yeah, just to say thank you to Alon Schwartz and his group to make this great presentation. Another interesting case, and looking forward for more cases for your service, sir, next year. And say thank you for everybody. You have 2 more meetings this year to finish well. We're gonna have, I already know 2 interesting cases coming the following weeks. So let's stay together and finalize strong this year. Thank you very much, everybody, for joining us today.